Hi, everybody. I'm Dr. Elisa Krill Jackson. I'm a breast medical oncologist at University of Miami. I specialize in breast medical oncology. I also do some GYN medical oncology. I was in practice for many years at a community hospital and have recently moved over to the university. And I'd like my co-hosts here to introduce themselves, Dr. Jain and Dr. Das. Take it away, Dr. Jain.
So my name is Dr. Shikha Jain. I am a medical GI oncologist at the University of Illinois in Chicago. I am also the Associate Director of Communication Strategies and Digital Innovation for our Cancer Center, and I'm the Director of Communication Strategies for the University of Illinois Department of Medicine. And I'm also the chair and founder of the Women in Medicine Summit and the COO of a company or a group of, called Impact, that is about amplifying evidence-based science and information in this pandemic and hopefully beyond as we navigate through public health crises.
And Dr. Das?
Yeah, I'm Dr. Millie Das. I'm a thoracic oncologist, and I'm a clinical associate professor at Stanford University, and also work at the VA hospital in Palo Alto, where I'm also chief of oncology. And I'm really thrilled to be here to engage in a discussion that's near and dear to my heart.
Okay, so I think 2020 has posed many challenges for us. I think one of the hardest has been how we're dealing with family, both children, parents, and I think it's been especially hard on women physicians. I have older children, but it's affected me because my oldest son can't or won't fly home to visit us. So it's been almost a year since I've seen him. And I have an elderly mother in Ohio that I didn't visit for almost 8 or 9 months before I finally felt comfortable enough. Testing was easy enough and travel seemed safe enough to go see her. But I feel really bad for my colleagues who are trying to handle young children who may be home and doing virtual school. Tell me about your guys' experience with your families during this pandemic.
So I can start. I have a 6-year-old. She turned 6 actually in May in the middle of the pandemic. And then I have twin boys who just turned 3 last week. And it has been a challenge. My husband is also a physician. And my daughter's school was virtual from, it started virtual in March and then all the way till the end of the school year. And I mean, it was challenging. My husband and I both work full time. He is in private practice. I'm in academics. My boys had no one to play with other than each other and my daughter, who was trying to get her virtual learning done. And she started to despise being on Zooms and on the computer. I also have my parents live in the city, so we're fortunate that they live nearby, but they also helped out with childcare quite a bit before the pandemic. And for about 4.5, 5 months, we didn't see them because I didn't feel comfortable. And my husband, when he was on call initially, before we knew much about the virus, he would go quarantine in his parents' condo that was empty because they live in Michigan and they have a small condo here. So I was essentially solo parenting in the evenings, many nights when he was on call. My parents couldn't come over. We tried FaceTime. My daughter wasn't learning in her virtual learning. And I felt like I was failing at work because I couldn't juggle my home life and my work life. And it was a challenge. We are now, 7, 8 months in, and I feel like we've figured out a little bit more of a balance and we found some safe ways to engage with my parents and have them come over. We all wear masks when they're here. We try to limit our exposures and, we're trying to be as safe as we can, but it's definitely been a challenge. And I know I'm not alone in these struggles that we've been having here.
Yeah, do you have help that comes into your house to help with the children during the day?
So we do. I have a nanny, and we have also been very, very strict as to who she can interact with, what she can do. But that's another level of stress because we're not going home with her. We don't have a live-in nanny. We don't know if she's going, and doing things without our knowledge. I trust her. I trust her implicitly. So that's why we kept her throughout all of this, because without her, we wouldn't have survived. I mean, we wouldn't have made it. One of us would have had to have left our jobs.
And I wonder also, I know one of my colleagues, her husband was actually a hospitalist on the COVID wards, and they lost several people who were taking care of their children because the person taking care of their children didn't want to be exposed through them, you know, from their jobs. Have either of you experienced that?
So I haven't personally. I've had very transparent and open conversations with our nanny, and I told her, if you ever feel uncomfortable, just let me know. You know, I told her our hospitals luckily have had enough PPE, so we've been fortunate, and Illinois' response was really great, and I think that our leadership did a great job of getting things under control. Now numbers are rising again, so who knows what's going to happen? But at least so far, we haven't had any concerns of our nanny leaving us. Fingers crossed.
And Dr. Das, tell us about your experience.
Yeah, a lot of what Shikha said, I could really relate to. I have a now just recently turned 6-year-old and a 9-year-old, and my younger daughter was in kindergarten when all of this, started back in March, and though the school immediately went virtual. She absolutely refused to do virtual. So she would not allow us to even turn the iPad or the laptop on, and which put my husband and I in a really difficult situation. We ended up actually doing Zoom sessions with her teachers 3 days a week, and we homeschooled her. And in that time that he and I were sort of trading off, and for me, I'm a physician with clinical duties, and so there were just certain times that I had to not be at home. My husband is a PhD scientist, actually working on the COVID vaccine, but working from home. And so between the two of us, we were trying to juggle sort of making sure we were learning how to teach her and getting her assignments completed and turned in. And unfortunately, the time that we were spending doing that, we had to sort of make up on the evenings and weekends. And about 2 months into this, we realized it just wasn't sustainable. It was really difficult to find a balance. And we were able to send her back to school in person because she was going to a private school, a very small private school for her kindergarten. And they understood our circumstances and did allow her to be sort of the exception student to attend in person. And that worked out for sort of the rest of the school year for us. Then the summer posed its own challenges because there were very few camp options. And at some point in the summer, I decided that I had the same feeling of like not feeling like I was doing a good job at home with the kids or at work. And so I ended up taking a leave of absence in the month of August from my clinical duties. And I got somebody to cover my clinics during that time, so that I could really focus on being with my children. And I have no regrets about that. And I knew that my patients were getting well taken care of, but it was very difficult. It was kind of touch and go. And we were trying to figure it out as things went along. And as everyone knows, there's just a huge amount of uncertainty. And here in California, we were also dealing with the wildfires. So even though, schools, so again, our private school was allowed to kind of go back in person with the start of this school year, there were several days that they were relying on students being outdoors, and that was canceled because of the smoke from the wildfire. So there was kind of multiple catastrophes, a lot of uncertainty. I think it was a lot to deal with as a mom, as a doctor taking care of like really sick patients, and then as a wife, there was a lot of kind of juggling responsibilities, and I'll say that it's ongoing. Every day kind of brings its own challenges, but I do feel that things have leveled out some, and we're hoping that we can all just continue through this and get through this together.
Now, do you think more of the onus has fallen on you guys versus your husbands? And do you feel at all, Millie, you said that you felt that it was hard to feel that you were being a good clinician and a good mom at the same time. Do you feel that as females, we have more of that imposter syndrome and look for higher standards for ourselves, and that the men handle it emotionally better than we do?
I do. I think there is some of that. And I think we do, we do, for better or for worse, hold ourselves to these standards. And, I, you know, I really felt like something had to give. And it's interesting because my husband didn't end up feeling that way. And that was, so it was a choice I made. And, and it's hard, he didn't force me to do that, of course, and it was something that I ended up choosing on my own, but it was just one of those things that it's, you know, I do think that there was a special, emphasis or stress, I think, on women during this time, particularly those, with young children and I think some of the child rearing, the majority of that does fall onto women.
And Shikha, what do you think?
Yeah, so I actually had a unique situation because I was transitioning to a new job. So I was leaving my old job and starting at a new job in the middle of the pandemic. So that added a whole other level of stress. My husband he's been in the same job for the last 6 years, and he's happy with his position. And he felt, because he's a gastroenterologist, so I think his bigger stress was they were losing a lot of their elective procedures. And so thinking about our finances and thinking about how, we were going to be able to maintain our mortgage. And we actually ended up transitioning our daughter into private school as well, because the virtual wasn't working. And so that, all of those things, I think he was more stressed about that. And I was more stressed about kind of the mental health of our children and my mental health and trying to get everything done. And I wasn't sleeping. I mean, my husband, actually, we made a deal where I was going to start going to bed before 2 a.m. because I was staying up really late trying to exceed everyone's expectations on everything that needed to be done. And my husband said something's got to give. So I think I may have been more stressed about that type of thing. And he kind of thought it'll all work out. But I do think that, at least in our relationship, he realized the amount of stress it was putting on me, and he tried as much as he could to offload some of it. Like when he'd come back from a week or two of quarantining, he'd say, okay, I know you can't do anything fun, but you need an hour without the kids because you've been working from home. You need, go do whatever you need. If you need to just sit outside for an hour, go do that. So, and before that was not something he would ever think of on his own. It'd be something I'd have to say, hey, I need a break, or I need to go do this. So I think it changed the way he saw the amount of work and effort goes into coordinating all of that, because we were both home a lot more. And so he tried to help with virtual learning when she was doing that. And we were both running around like chickens trying to figure out how to get my daughter on her kindergarten and my boys on their nursery. And then she needed help. And then the boys had a technical difficulty. And I mean, literally we were just running around the house and nobody knew how to handle it. So I think we handled the stress and we talked about it, and the things we got stressed about were different. But I think it actually helped him understand a bit more of the challenges that I face as a working mom.
Yeah, I think that brings up another point. I think, a lot of us, when we have stressors at home, work can be stressful, but I think there's a lot of really gratifying things in our jobs. I mean, that's why we're in medicine, because we love taking care of patients. And I think the pandemic I wonder if you feel the pandemic has made our jobs a little less satisfying. The transition to more video visits. I don't know if your universities did a lot of telehealth for a while. The lack of touch with our patients. I know in Miami, visits usually start with hugs and kisses and end with hugs and kisses, and that changed quite a bit. And that was always, a very gratifying part of my job, is being able to hug a patient when they needed it. And for many, many months, we were doing nothing like that, So I wonder how you feel about your clinical satisfaction during this pandemic.
So I can tell you.
I couldn't agree with.
Go ahead, Millie.
Oh yeah, I mean, for me too, the therapeutic touch was something that, I missed, and it goes both ways. It's not just the patients; it's really for the providers as well. And I think that pivot to telemedicine, it happened everywhere, and it was. I think it was necessary. I think it has opened a lot of doors for, patients who wouldn't have otherwise been able to see you because of the long distance. I think that they get a lot out of it, but I think as a clinician, it hasn't been as satisfying, particularly for those new patients that you're seeing over telemedicine. I think it's really, really challenging. The ones that and have relationships with it, I think it's worked a little bit better for, but the new patients, and we've been doing both new and follow-up appointments over telemedicine, and I find it very difficult. And then just having that, being able to forge that connection with the patient. And of course, I live in the heart of Silicon Valley, but there's pretty much every day there's some issue with internet, either on our end or the patient's end, and so that also just adds this whole element of frustration for everybody.
Yeah, I couldn't agree more. And I've had to have hospice discussions over telemedicine, which breaks my heart. I mean, I talked to a really young girl the other day, and we had to have a really difficult conversation, and her family is like holding the phone up so she can talk to me. It broke my heart. And then one of my patients who I've been seeing for years, I had to have a hospice discussion with him yesterday, and I couldn't hug him because our numbers are going up so much. We can't. It's just not safe. And I feel like that human connection, we've really lost some of that with all of this. I mean, the flip side is I've been able to communicate with a lot of my patients more in some ways, because patients who aren't able to make it to appointments are more likely to make it to their telehealth appointments because they're sitting in bed. But I think that connection that you have with patients, and I totally agree with you, Millie, the new patients especially, it's so hard to develop that connection. And then on top of that, the mask. I mean, when I'm meeting with patients in person, having that mask, most of my patients have never seen me smile. I show them my ID badge. I'm like, this is what I look like when I'm smiling. Keep this in your mind. It's all of it is just making that connection so much harder. And, you want to have that deep relationship with your patients. And when they can't even see your face, it's hard to do that.
I love what you said about, the patients not knowing what you look like. So I've had, several patients that I've been seeing, for months getting chemo in person, and they only see me with my mask. And then one of my patients had surgery after neoadjuvant chemo, and we had a telehealth visit to discuss her pathology report. And she's like, oh, this is what you look like in person, because I had my mask off for a telehealth visit. I found telehealth exhausting. I found, seeing 20 plus patients a day in person so much less exhausting than doing, 15 telehealth visits. I wonder how you guys felt with that, and did you do those from home or from the office, and did kids make a difference with that, or how did that work for you?
I did everything in the office, and when you work at a academic medical center, even at the VA, we work a lot with fellows and NPs, and so even when we were doing video visits, we had masks on because we were in a room with other people. And I agree with you. I found it extremely exhausting, and especially with these shared visits with the nurse practitioners or with the fellows or students, you'd end up on the video for much longer because they're doing an initial visit with the patient, and then you go in, and so it's just everything took a lot longer, and there wasn't it just wasn't the same sort of flow, and I think that's why it felt really exhausting. I haven't tried to do any video visits from home. I've really pretty much tried to keep kind of my work and my home life separate, and mostly because I know that I'd have a really difficult time trying to get work done at home with young kids around. So,
and Shikha?
So I've done both. I've done televisits from home, Oftentimes they can hear my children in the background, and especially my patients who've known me for years, it makes them happy because they saw me pregnant with the twins, they saw me pregnant with my daughter, and so sometimes they even ask, can we see your kids? So that that happens occasionally, and I feel like in that way the connection is even deeper. But yeah, it's exhausting. I mean, not just because it's not just televisits that you're doing on the computer, you're also doing other meetings. I mean, I've had days where this is my home office, which really is just a section of our bedroom because we live in a condo. So I've had days where I literally am sitting from 7 in the morning until 5 in the evening on the computer, whether it's clinic visits or meetings. And I have headaches, my back is hurting. I mean, I'm exhausted. I one day realized I hadn't stood up in 6 hours. I literally been sitting in place for 6 hours. So I started timing in 5-minute breaks so that I could go out, get a drink of water. I would see my kids in between meetings sometimes or in between visits. So that kind of rejuvenated me, that was a nice change from the past where I'd be in clinic, you know, from 7 to 6 and didn't see my kids until late into the evening. So at least I had that when they were home doing virtual learning, and I had that benefit, you could say. But yeah, it's exhausting. It's really tiring.
Yeah, I was surprised at how exhausting it was, and how much less, you get out of it emotionally. Although, there's a few bright points to it. I loved seeing patients' homes, seeing their pictures behind them, seeing their dogs, occasionally seeing, their children wandering through. In my field, with breast oncology, a lot of times there's things we have to see. So I've had patients, strip on the video visit, and you're like, is anybody in your room? And it seems a little risque, but it's worked. And, I'd like to see video visits continue because in a small portion of our practice, because I think it's great when somebody calls up with I have a skin lesion, or I have my mouth hurts, and you can sort of see it online and they don't have to rush in, or just to go over results. You see them, there's a problem, they get a CAT scan, they don't have to come back 2 days later for a whole visit, especially if you're downtown and they live farther away. You can go over results by video. But those first visits, or sharing bad information, that's very, very hard on a video visit. And I've been glad that we've gone back to mostly in person. Let me ask you guys a question, because we're constantly reworking this. What are you guys doing about COVID testing your patients who are getting chemotherapy? Are you COVID testing them before they get chemo? Are you doing that on a regular basis, just once? What are you guys doing?
I think it depends on the week right now with our with our numbers in Illinois going up so rapidly. I mean, at one point we were testing people before they were getting chemo. Now we're not. We're not testing people before they get chemo. Anybody who gets admitted does get a rapid COVID test before they get admitted to the hospital. People obviously who come in who were, like, I had a patient yesterday who had a contact, so she got tested before chemo. So the only time we're really testing people before they're receiving chemo is if they are having symptoms or if they had a contact. That's this week. I don't know what next week will bring. But yeah, everybody who's getting admitted does need a negative COVID test before they get admitted to the hospital that day.
I'm sorry, unmute. That's the phrase of 2020, I think. You're on mute. Millie, what are they doing at Stanford?
Yeah, so in lung cancer, it's been interesting because there's symptom overlap between lung cancer, cancer-related symptoms, and COVID. So we were pretty much testing most of our patients in the beginning of this. And then the recommendation now is that we test prior to starting IV cytotoxic chemotherapy. So not necessarily oral targeted chemotherapy or immunotherapy. We are testing as a group, as a thoracic group. We decided we would test our patients prior to start of cytotoxic chemo. certainly at the, if patients have any exacerbating symptoms, again, it's very tricky in lung cancer because a lot of the times we think it could be related to cancer progression, though, you can't be sure. And so we err on the side of caution and we do the testing. It seems to be more widely available. Insurance companies are paying for it. And so it's something that, we are doing. And then, they leave it up to the provider to decide whether to repeat testing every 30 days. Honestly, my approach is to ask the patient. I mean, it depends on the test getting performed, but it's not a very comfortable test for a lot of patients. And I've really kind of seen it both ways. I have some patients who really want to make sure they want to get tested, every 30 days, and that's totally fine with me. And there's other patients who say, I'd rather avoid it if at all possible. And so I'm not retesting those patients. Anyone undergoing radiation, it is required that they have a COVID test. And as Shikha mentioned, getting admitted, they do have to have a rapid test. And so there's certain circumstances where we are having to routinely test. But in the outpatient clinic setting, we are doing it at the start of cytotoxic chemo and then, considering it every month or so.
Yeah, that's what we're doing before they start their chemo, but then they're coming in every 3 or 4 weeks to get their chemo and we're not retesting, which, we're relying on them to be careful at home. But certainly I've had many patients between cycles of therapy develop COVID. So, it doesn't seem to make a lot of sense to test just before you start, but, I think we're all doing the best we can. And I don't think it's feasible really, to test everybody, before every cycle of treatment. I think it's hard enough to be a cancer patient and come in that often for chemo. So it's, we've been learning on our feet. I mean, luckily, I think we've gotten more of a handle on the symptoms, and with rapid results, people don't have to wait a week to know whether they have it or not. So that's been helpful, but that's been an added challenge and an added stress for our patients. And it hurts me to have to tell a patient, no, we got to delay your chemo until we can get your COVID test. We can't start it. We have to organize this. They'll often have to get a COVID before their surgery, and then before their first chemo, and then before their radiation. And if it's more than 7 days, we're making them do it again before they start. It's been frustrating and a moving target, and making, I think, cancer treatment much harder for our patients. Have you guys changed any of your therapies that you would normally have given your patients because of the pandemic?
So I have, for example, Folfox is something that we use often, which is, 5-FU, leucovorin, oxaliplatin. I have started using a lot more of capecitabine and oxaliplatin so that patients don't need to be coming in every 2 weeks and can come in every 3 weeks instead. So
I have to come in to get the pump off as well.
Exactly. So I'm trying to think of ways that we can kind of change the therapies, not to change them to less effective therapies, but just ways to decrease the number of visits. I was one of the holdouts when it came to things like nivolumab and doing it every 2 weeks, because that's how it's always been done. And I was having a real tough time changing to the every 4-week plan, but I've done that for most of my patients who are, if they're receiving that for any reason as well. So any treatment where I can find a way to decrease the number of clinic visits and decrease the amount of time they need to be in the clinic, I have done that, making sure that I'm not sacrificing their care in any way, shape, or form.
And Millie, how about you with lung cancer treatments?
Yeah, I haven't really changed my practice. I mean, I was already out of, for patient convenience, trying to do the Q4-week nivolumab and the Q6-week pembro dosing. So I can't say that the pandemic has changed that as much. And I would say by far and large, most patients wanted to continue on their regimens and didn't want to delay because of COVID. And so it hadn't really changed my practice that much.
Yeah,
I'm curious.
I'm sorry, Millie, you broke up.
Just curious to know, in the breast cancer treatment, were there any significant changes that you implemented for your patients?
So a few, we give a lot of neutropenic causing regimens. for adjuvant therapy. And initially I was giving a lot more Neulasta than I usually do. I usually don't give Neulasta for 2-3 week regimens in younger healthy patients. And so I started out by, when we knew very little about the pandemic, by giving them Neulasta. I ended up with, a lot of bone pain and a lot of, day 8, very high white counts, after the first cycle in patients due to the Neulasta, because they didn't really need the Neulasta to begin with. So I've backed off a little bit on the Neulasta because also we haven't really seen our neutropenic patients getting, they're neutropenic for a couple days maybe, and we haven't really seen them getting, terribly sick or hospitalized. So I've backed off on that. Initially, some people I think were holding off on giving CDK4/6 inhibitors with hormonal therapy because of the low white count. I never backed off on that because I thought that was an important therapy, but I made sure that their dose wasn't causing severe neutropenia. So I'd say at this point, I haven't made any sort of permanent changes in my regimens, and I'm practicing pretty much as I always would. And I think that's important because, when you have a curable malignancy, you certainly want to give them the best care. And when you have palliative care, what we do makes a difference in terms of their overall survival. So I haven't been changing much. Have you guys seen effects of delayed diagnosis in your patients because they haven't been they've been afraid to go to the hospital for symptoms, or they haven't gotten routine colonoscopies, Shikha?
I have. I've actually seen some very young people with colon cancer that started having symptoms right at the beginning of the pandemic. And literally the words they said to me was, well, I would have normally gone to my doctor, but I was too scared to go in. And they were having rectal bleeding for months before they finally got it checked out. So I've seen it in younger people. I haven't necessarily seen it as much in older people because a lot of people, their colonoscopies, like surveillance colonoscopies, are getting delayed by 6 to 8 months at this point. I expect in the next year or two, we will start seeing a large number of people who delayed their colonoscopies, and we start seeing those later cancers. But the majority that I've seen now have more been younger people who didn't go get some symptoms checked out when they normally would have gone to their doctor.
And Millie, how about in thoracic oncology?
Yeah, I've seen a few instances of this as well, particularly from the standpoint of patients delaying their low-dose CT scans, just for screening purposes. I had a patient that I saw recently who had a suspicious finding on a CT in March and was recommended to have a follow-up CT 3 months later, and ended up, the patient ended up trying to avoid getting that done. And, unfortunately kind of waited an additional 3 months. And so ended up getting it at six months. And, by the time they were referred to pulmonologists to get a biopsy, the pathology came back as small cell lung cancer, which of course we know is very aggressive. And it's one of those cases where, if we had been able to biopsy this patient earlier, I think we, could have done better as far as, better treatment options for that patient. So, so I've seen it in a handful of patients. And, I think even for patients who are, quote unquote, cured, from their early stage lung cancer, we know that these patients have a very high, likelihood of recurrence and, should be getting their surveillance imaging. And so I've been doing a lot of telephone calls with patients just to basically check in with them. And, so these are patients who were on my schedule, but then they canceled and their appointment was canceled because they didn't get their scan. And so instead of doing a video visit, I call them up and I say, hey, let's figure out when you feel comfortable coming in to get a scan, and we'll try to do it so that, again, it's up to the patient if they wanted to try to get their scan on the same day as a appointment in person, or get their scan, go home, and then do a video visit with me. We've been trying to do it that way, but it's more just, me checking into, and because things are, changing so frequently and everybody has a different risk tolerance, it is very much individualized, and we're trying to capture these patients and kind of remind them that their cancer surveillance is also important. And at the beginning, I think a lot of us were hoping and thinking that this was just going to last 6 months or something. And, when we'd all kind of get back to normal, and we know that this is now drawing out a lot longer than we wanted, right? And so it is really important to loop back with those patients who maybe in March, April, May didn't want to come in, but, it's not really okay to put it off a year. And so there is a lot of this kind of looping back with patients and trying to figure out when to bring them back in.
Yeah.
So I was just going to say one other really sad situation that I've seen happen to a couple people is right around February, they were planning on being enrolled in a clinical trial, and then the clinical trials got put on hold. And so I have several patients who kind of fell off the radar because they'd gone to another institution, they were being evaluated for clinical trial. They were told, we'll get in touch with you. And like Millie said, people thought it'd be a short amount of time and then things would get back up and running. And during that time, while they were waiting for the trial to open back up, they didn't reach out to their primary oncologist, so they didn't know that they hadn't been enrolled. And then they progressed during that time. And then when they got reevaluated several months later, by then the cancer had progressed. They're no longer a candidate for the trial, and they're in trouble. So I've seen that a couple of times as well, where people have come to me as a second opinion and that situation has happened. And it's just unfortunate that, that this has happened. I mean, it's just a disaster.
Yeah, I think the clinical trial thing has been really hard. I mean, I think part of the joy of being at a university practice is being able to put patients on innovative clinical trials. And, they pretty much, we always kept them going in our university, but in a limited fashion. And so it was hard, it was hard to have something you could offer a patient, but, the study was on hold nationally, or there wasn't the manpower to do it because all our research assistants were really working from home. It made it much more difficult. And I think it took some of the joy out of our daily work life that, is why we went into medicine. We've seen a lot of mammograms, people putting off mammograms, and people who had breast masses, either afraid to work it up or really unable to get through the system. In the early pandemic, when people shut down, we always did, mammograms for symptomatic patients, but I think a lot of people had trouble accessing the system, when they felt a mass. I just saw a new patient the other day who, felt a mass in February, and she wasn't really able to get any workup until June or July for it. So, I do think there have been some delays, hopefully, and I'm sure there are some patients who are going to have worse outcomes because of that. One other topic I wanted to bring up is accommodations we're giving patients. I don't know if you've been getting the same phone calls and emails I've been getting, but I've been getting a lot of phone calls from patients who had chemo years ago, many school teachers who don't want to go back to work in person. And they want us to write letters saying that they are higher risk for severe COVID and they should stay home. My kind of rule of thumb is I'll do it if you're within 6 months of chemotherapy, but I don't think there's any data. In fact, I think there's good data that patients who had chemo years ago, aren't on active treatment, do not get more severe disease if they have COVID. But yet they're reaching out to us. And I think, some patients are happy when you tell them that you're not at higher risk, and others are just angry that you won't write them the letter. Have you guys experienced that?
I have not.
Millie?
And it's different patient demographic. Yeah.
Yeah, I haven't either. I'm curious as to what I would say if someone reached out with that request.
We've been getting it a lot in the breast cancer group, because we have a lot of young women, we have a lot of teachers who we've treated, over the many years. And, we get this request frequently, and I have some partners who will write a letter for anybody that says, they had chemo in the past and they may be at higher risk for severe disease. Can you accommodate them to work at home? And, I just don't feel I can write that for every patient who had chemo, 3, 4, 5, 6, even 10 years ago. I mean, somebody has other underlying illnesses or they're, 65 and above, sure. But, these are young women. And I think that's, made a little bit of anger among the patients, but sort of like disability forms, that we often have to fill out. So I think we've gone through most of the topics that I wanted to talk about for this in terms of being a woman in 2020. But one more, in terms of academic medicine, do you think that the pandemic has changed females' trajectory in terms of their career paths in academic medicine because of, increased childcare responsibilities or not being able to be at in-person meetings? Or do you think that it really hasn't changed anything?
So I can address that. I absolutely think it has. Actually, I know it has because there's data coming out showing that it has. I will say that the silver lining out of that is I've seen a lot of really innovative and interesting solutions come out of this pandemic, and I'm hoping that some of those get implemented. I wrote a paper, actually a CV matrix with some colleagues on how women especially can account for their time during this pandemic and put it in your CV, which I think is very important because even though you may not be doing traditional academic work, you may have been, launched into leading a COVID unit or, a COVID task force. Those are all things that need to go on your CV. You may have had to take a month off because of, childcare. Those should go on your CV, and we've created a way for you to be able to do that. We've seen a lower number of women as first authors and senior authors and being submitted to journals. We've seen less women who are presenting at conferences and things because of the challenges that you mentioned. So we've put out papers to talk about that and to be intentional in addressing that. One cool thing that's come out of this pandemic, we've created a Women in Oncology publication through the Helio platform, which I'm the consulting medical editor for. So we're trying to provide a way for more women to show the work that they're doing and amplify the work that they're doing. So I think that I know that it has the potential to make a huge impact and have a lot of damage to many women's careers, especially in academics. But my hope is that we are utilizing this information and seeing what happened in the first half of the pandemic to really mobilize and create infrastructures to prevent that from happening. And instead of losing a significant amount of ground, hopefully we'll be able to change the system and create infrastructure that allows women to excel, utilizing what they have learned and had to do throughout this pandemic, as opposed to penalizing them for not being as academically productive because we've been living through a public health crisis. And to be perfectly honest, women have been the ones leading a lot of these initiatives across the country. And I wrote a paper on something called the third shift, where women are largely responsible for doing this DE&I work and not getting credit, and it doesn't go towards your promotion, it doesn't go towards your professional development. And I hope that this pandemic has shown that that work all needs to be compensated and acknowledged for professional advancement.
Well, Shikha, maybe we can share the links to those articles in the chat or at the end of the Evolution Conference with the people watching this, because I'd be most interested in reading these articles you've written. Maybe you can email me them. And Millie, what do you think about that? Have you noticed that?
Yeah, I totally, I absolutely think that this has affected, women's career trajectories in academia. And I love those efforts that Shikha's mentioning. I mean, I'm aware of that. And I think it's really great. And I think we need to acknowledge this. And I have been seeing some publications that are coming out. It was in the New York Times not that long ago, just, really kind of putting it out there and, and so that you can have a conversation about it. I will say that I found that, just Stanford and the VA and, our workplaces have been really understanding. I mean, I've never, a lot of it, again, kind of me feeling like, I wasn't able to do X, Y, and Z because I was, kind of preoccupied with, things related to my kids. And but I think that our workplaces have also provided some great accommodations, and realize that we're not going to be able to be in our offices all day, and allowing for more flexible work schedules, and I appreciated that. I think a lot of it, just sort of this sense of not being able to achieve as much is really kind of internal, and I think that it's nice to see it more widely acknowledged, and to hear people talking about that. And it is something that I think has disproportionately affected women over men. I do also, kind of want to recognize that men have been impacted as well. But I do think that we as women have been more impacted, and to be able to talk about it openly, and to be able to, I love the idea of being able to put on your CV sort of the things that you were doing, and maybe had to, I know as chief at the VA, there were a lot of just policy changes that I was involved in, and so even in the time that I wasn't seeing patients in clinic, I had to work with hospital leadership just to figure out how best to keep our patients safe. How do we avoid having a waiting area, and just getting kind of involved in those kind of nitty-gritty discussions and decisions. And it was time consuming, and coming up with testing policies and things like that. So I think when you're in these roles, and you end up having to spend quite a bit of time doing that, of course it's going to take away from the time that you would be spending writing a paper, or collaborating with researchers. I think that, another sort of silver lining, though, is to think about, these conferences that we all attend, and they all turned virtual. I, for one, actually thought that the virtual meetings were quite effective. I felt that I was able to attend more of the meeting than, so for us, and it's ASCO, for most of us in oncology. And, it was great to be able to sit there on over the weekend, and to really kind of catch myself up on all the abstracts that are getting presented, and I may not have been able to catch them in real time, but I was able to sort of go through it and in my own time, and I thought that was great, and I may even consider this for future years. Of course, there's things that you lose attending the conference virtually. A lot of the things that you miss, just meeting with colleagues in person and things like that. But I was pleasantly surprised at how effective it was, these conferences were in kind of disseminating the important information that a lot of us are putting into, clinical practice.
Yeah, I also think just our local conferences like tumor boards, we have a huge campus with multiple different satellites, and it was always difficult for people to attend because the audiovisual system we had wasn't great. But, with Zoom, you can see the pathology and the radiology easily. Everybody can hear everybody else. And I'm not sure we should go back to in-person tumor boards, or, if we do some sort of Zoom hybrid, because it has allowed so many more people to participate who, couldn't be there at that hour because they're at a different campus. So I think that has definitely been a silver lining. So, I think 2020 has brought some lessons, both good and bad, and definite struggles. And I'll be glad when we're in a new year, and hopefully the pandemic is running down a bit. But it has been a challenging year, I think, physically, emotionally, everything. And I really appreciate you guys joining us in this conference. And thank you so much.
Thank you.